Good evening, everybody. Welcome to Cancer Decoded. I'm Mark Halperin. Thank you for joining us. We have a great show for you tonight. As always, our goal twofold: present you the best information about cancer, cancer research, cancer treatment, cancer regulation and science and government regulation, and also to create comfort for what we hope will be and plan to have be the largest cancer support community in the world. And very grateful to you for being here. If you'd like to be part of the conversation, some of you have already done this. If you're here on the two-way platform, please raise your hand. If you're watching on X or YouTube, we're grateful to have you here. And please share the existence of this show with people you know, whether they're dealing with cancer currently or not. This is an opportunity for people to ask questions and to understand how we all meet this challenge together. And again, grateful to have you here. Dr. Patrick Soon-Shiong and I are delighted to host tonight Senator Bill Cassidy, who is a doctor, senator from Louisiana, who is, in my experience, dealing with people in Congress and the executive branch, truly one of the most knowledgeable people about public policy and public health that I've ever dealt with. Maybe not a surprise because he is a medical doctor as well as a senator and someone who understands both government and the private sector. But nonetheless, we couldn't be happier to have him here. He'll be here in just a moment, and he will be taking your questions. He's been engaged in the question of how we provide the best healthcare in America, the best public health, and extremely involved with given his chairmanship of the Health Committee in the Senate with all the major decisions the country's facing now. So he'll be here in just a moment. As always, as I say, we welcome your questions. And as always, I start with Dr. Patrick and talk about some of the latest news going on in cancer today. So, Doctor, I don't see your camera, but I'm wondering.
Can you hear me though, Mark?
We can hear you. So we'll start while they fiddle with your camera. We'll start.
Okay.
Grateful to have you. And I as always, enjoy spending Tuesday nights with you, talking about all these issues. First thing I want to ask you about is about China. A couple of stories in the news this week. We can go ahead and put up a Bloomberg headline here. Number one, China's biotech advances are changing the world's drug pipeline. Obviously, China manufactures a lot of pharmaceuticals, a lot of issues related to our competition with China. And then a story in the Financial Times, Chinese biotech shares such as Big Pharma looks to license cancer treatments. So let me ask you a general question about China. Is cancer research something they're ahead of us in? What's the state of all that we compete with China on everything? Where does China stand in terms of cancer research and cancer treatment compared to the United States?
You know, I think that's really not only a concern, something that's very real. I've been watching the Chinese research papers and the science in cancer research. I think not only are they probably equal to us, they may be close to be ahead of us in terms of the development of drugs in the world of biologics. So they have figured out very early that we, beyond chemotherapy and radiation, they are the breadbasket, believe it or not, of some of the raw materials that make the chemotherapy. But very early on, they went into this whole era of biologics and immunotherapy and cell therapy. And I'm watching the science grow, and more importantly, they are developing, producing, and doing clinical trials with regulatory freedom of getting things approved. So my fear, as I sort of tweeted even this week, is that we have to wake up to the fact that it would be a tragedy that Americans would require next generation products from the rest of the world, including China.
Is there scientific cooperation with the Chinese, the way you would cooperate with your counterparts in Britain, the way you've been cooperating with folks in Saudi? Are they part of the international medical community, or are they keeping things to themselves?
Well, they're very much part of the international community, and then more so with Europe. You know, I have a colleague from Oxford who's been very much there, and they've been obviously a part of the community in the United States. But the concern now, you know, with the geopolitical tensions, and more importantly, how they've evolved so that they could have their not only clinical development, but regulatory development and approvals so that it can go into their population. And they've evolved their manufacturing capacity to that of biologics. So they've taken this evolution to a level very quickly. And obviously, with a population of over 1 billion people, their creativity is different from when we saw before within the Japanese or the Korean pharmaceutical industries. I think the Chinese have learned very, very much the basic understanding by spending a lot of time in the U.S. Academic institutions.
We talk all the time here about what causes cancer rates to increase, and we've talked about lifestyle issues in the United States that we think contribute to cancer. Where are the Chinese rate, as far as we know, in terms of rates of cancer? Do they have a public health crisis related to cancer as we do?
I think we all have a public health crisis, and more so in every part of the world, including China. As you know, there's also a genetic component. China have a very high incidence of head and neck cancer, high incidence of liver cancer, and high incidence of lung cancer. The Chinese, sadly, population still smoke cigarettes a large scale. So, and who knows what we can talk about that in the future, what COVID is doing or will do in terms of perpetuating this cancer pandemic. So, yes, they have a very high incidence of cancer, and they treat their patients in a very different way, which we can get into at one point, because most of the patients are hospitalized as part of the cancer treatment.
Okay, let's put up the headline number 3, please. It's from a publication called Health Day News. I think I've said this before in the program. When I go to the doctor, pretty much every time I tell the doctor I've got any complaint, my knees hurt, my back hurts, snoring, can't sleep, whatever, lose weight. Pretty much everything the doctor says, just lose weight. This headline suggests obesity-related cancer deaths more than triple in the U.S. What do we know about the relationship between obesity and cancer incidence and cancer deaths?
Well, I think the combination of metabolic issues, diabetes, comorbidities associated with that, including diabetes, and are related to the issue of cancer. And then, as I've been saying, it's really a function of your immune system. And as you get overweight and as you have diabetes and have you all these then actually create what we call immunosuppression in your body of the immune system. That's why diabetic patients have a high incidence of wound infection and less healing. So it's not surprising. There's a correlation. I'm not sure whether it's causal versus correlative,
Right.
but I think obesity is one of them.
Again, I'm joking slightly about my doctor, but it's true that most health issues you could stand to do better losing weight. If someone's diagnosed with cancer, is losing weight make sense? Dieting and exercise, or
well, there's a universal truth with cancer, like the universal truth with AIDS. You lose weight. So it's quite the opposite.
yeah,
What the cancer is a horrible machine in your body that's actually driving to itself all the nutrients, and it uses a protein called albumin that drives things into itself so that it can proliferate. So as you can ask yourself, a universal truth, regardless of the cancer type, you lose weight. And again, regardless of the tumor type, it's again the collapse of the immune system. So if you ask anybody about HIV and AIDS and the viral infection, you lose weight. And what is the common denominator of that? The acronym for AIDS is Acquired Immune Deficiency Syndrome. So if you look at this common denominator of this universal truths, regardless of the tumor type, regardless of the infection, the weight loss is the function of the disease.
Let me ask it in a different way, because of course I should have not asked it that way. If you get diagnosed with cancer, should you eat healthier and exercise to the extent you have the strength to do it, or at that point that's not going to help you?
You should always do that regardless anyway, right? At the end of the day, having said that, sadly, And, we can talk about this in monthly with this Cancer Decoded. Our treatments don't facilitate that. All our chemotherapies give you mouth ulcers. It gives you diarrhea. It has all these bad effects that actually allows, frankly, or disallows the opportunity to be able to eat healthily. And then you compound that with the disease itself. So the answer is it's really important for you to be healthy so that you can be strong during the time that, in fact, you do get cancer. And healthy is all related, again, like a broken record, to maintaining your muscle mass, reducing the body fat, but importantly, in maintaining a very strong immune system.
Okay, lastly, and then Senator Cassidy will be here shortly. And again, if you want to be in on the conversation, please raise your hand. We're all evaluating the senior public health officials in this administration. Secretary Kennedy, Dr. Oz. These are people with extraordinary public profiles, much more public than most, and in their previously in these positions. And they're all adherents to MAHA. They're all aspirational to really have a revolution in public health. But as you know, doctor, there's some people who are skeptical of them, who think they're changing the rules too quickly or changing the rules the wrong way. And I think from a journalist point of view, I think the verdict jury is not in. We don't know exactly how this is going to go, but we obviously all hope they're changing things for the better. Here's a FDA Commissioner Makary who fits in the mold of all the senior officials in the department. Very high profile, very intellectually provocative, iconoclastic, looking to change public health for the better. Here's the commissioner on CNBC. Roll number 4, please.
Cool things, Melissa, in this job is you get to see potentially promising treatments that are in the pipeline. And I'd like to see a cure for type 1 diabetes. I'd like to see more cancer therapies that apply to stage 4 metastatic disease and cancer therapies that result in what we call in medicine a complete pathologic response. That is, the cancer melts away. There already appears to be some therapies that may enable cancers to shrink and go away completely. That is, be eliminated without chemo, surgery, or radiation therapy. I'd like to see a universal flu shot so we don't have to try to guess each year which strain is coming. There are candidates out there. And I'd like to see treatments for neurodegenerative diseases and other disabling diseases. I had an aunt who died of Alzheimer's disease. I'd like to see more in the neurodegenerative space.
So, doctor, what do you think of that? Not just pertaining to cancer, but overall, what do you think of how he expressed himself there and the general policy of his FDA compared to previous ones, where many people in your business have been frustrated at times by the nature of the approval process of new drugs?
Well, he's talking from a perspective as a clinician. The way he's speaking there is, and the understanding, rather than from a position of a bureaucrat who's been in the world of government policy and government regulations and making huge decisions on behalf of the American public. And that's why, I'm so pleased to talk to Dr. Cassidy, and that's why Dr. Makary, Marty Makary, has been a clinician, and I think at Johns Hopkins. And we as clinicians and as doctors really see the suffering so when he talks about pathological complete response, that is really in the world of cancer, where exactly that, before surgery even, you found a way to remove the tumor completely from the body. We will talk a little bit about when he says no chemotherapy, no radiation, etc. You begin to sort of see that that is not only possible, but if we have this enlightened stage of understanding that we do not need to put patients through this, literally I would consider medical torture of these terrible drugs, with the idea of getting a tiny response called a partial response. That's a response rate where only less than about 50% of the tumor shrinks. So speaking as a clinician from his perspective, I resonate with that because rather than being a bureaucrat and checking the box, what really matters to the patient is the quality of life, increased life, longevity of life, and freedom of the disease. So when I hear what he speaks there through that, it resonates very much with me.
Okay, thank you, Doctor. Joining us now, I'm going to do 4 quick things. I'm going to introduce Senator Cassidy. I'm going to ask one question, and I'm going to turn the 2 doctors to talk to each other. And then my job is to simply step in if they're speaking doctor speak and no one can understand what they're talking about. And then we'll go to your question. So,
Mark, is the camera now back on?
Yes, sir. We see you fine, Doctor.
Okay.
Senator Cassidy is 4 things that we should want in every public servant. He's hardworking. He's very smart. He's kind, and he takes his responsibilities to the American people seriously. So, couldn't be more delighted to have you here, Senator. Thank you for joining us.
Thank you, Mark, and Patrick. Thanks for having me and all the guests. And looking forward to speaking with you as well.
Okay, so I'll ask one question. Then we got lots of hands up. So, the doctor conversation will go for a bit, and then I'll jump in and start bringing community members in. Doctor, what is the role of the federal government in the fight against cancer if it's being executed correctly? How should it be working?
If it is executed correctly, that's an interesting, multifaceted question. One, it's clearly been a prime funder of research, and it's done that through the NIH and by other means, but principally through the NIH. Secondly, the FDA controls access to drugs. So if Patrick's got a great drug, he's got to bring it to the FDA for approval. Thirdly, it's also got protection for human research subjects, and so you want to make sure that these trials are done ethically. So that's first. Secondly, it's through medical education. The degree that the federal government facilitates people becoming the scientist or becoming the physician who treats these patients, that's good. And lastly, my practice was in a hospital for the uninsured in Louisiana. And so most of my patients had no insurance or Medicaid. And so I'm also very aware that for some people, there can be a difficulty in accessing care. And so in our system, the federal government sets up a safety net in which for both those over 65, I used to call them elderly, I don't anymore. And for those who are lower income, they provide that insurance to help provide that access. I could probably keep going, Mark, but that's a great way to start.
Okay, Senator, Doctor, thank you. I turn it over to the doctors, but I'm warning you, I'm stepping in if you speak doctor speak. Patrick, go ahead.
Well, Senator, first of all, thank you for your time. I know you're really busy, and there's a lot of subjects I'd love to cover with you. I'll just sort of list them off, and we can talk a little bit cancer. And I understand that your wife was a general surgeon, and I love surgeons, so we can talk about how that has influenced your thinking. I've always said what our Senate's needs and our congressmen need are more doctors. We have a $5 trillion healthcare budget, and we really need somebody like Senator Cassidy who understands the touch and feel and the struggles of patients, especially in rural medicine. But I want to talk to you a little bit about cancer. I want to really talk to you also about the big, beautiful bill in Medicaid and your thoughts on that, and a large amount of information and disinformation. We just put some papers out today in our newspaper about the Medicare fraud, a $14 billion Medicare fraud. I want to talk to you a little bit about China and our concerns about the raw materials in China. So obviously there's a lot of subjects, but I'm going to try and keep it as tight as possible. But let's talk a little bit about, Senator, about your wife that was a general surgeon with breast cancer. And really, how has that influenced you and helped you shape your understanding, especially in rural, as you said, uninsured? How does it help shape your thoughts in cancer? And I have a question about, maybe for your wife, about the chemotherapy that's being used in breast cancer.
And so Laura no longer practices, but she has that general surgeon's intensity that she brings. I see there's several MDs in the audience, and you know that intensity that general surgeons have. She did our medical residency, our surgical residency at Harvard UCLA. And so excuse the pun, but in Southern California in the early 80s, that was the cutting edge of how to do breast cancer in a most sensitive way to how the woman would live. And so, for example, when we returned to Baton Rouge, she's from Mobile, but we came back to Baton Rouge, most people were still doing mastectomies for breast cancer. And she was the first surgeon doing typically lumpectomies, minimally invasive surgery, trying to conserve the breast as she had been taught in Southern California. So it's innovation being patient focused. And that's
Wow.
really, as we try and resolve the cancer, whatever, it has to be innovation, which is patient focused. She also brought kind of the perspective of a woman. People ask me, what's a barrier to getting treated for cancer? And first is screening. Now, I did a lot of colonoscopies, and there's a lot of people that cannot imagine having a tube stuck up their yang yang. But the reality is that we give you so many drugs, you wake up and you say, "Hey, I'll have another one." You know what I'm saying? That felt so good. And what Laura taught me, it's going to be a little amusing, but it was a cartoon she had in her office. She had a cartoon because a reason some women don't get mammography is because they have to squeeze the breast between the plates, and it's very painful. And I said, "Baby, how painful can it be?" And she showed me the cartoon, and it showed a man with his genitalia between the two plates being squeezed. And she goes, and the caption says, "How does that feel, Buster?" And so she brought that perspective of someone who could relate to someone with breast cancer, both their fears, maybe they didn't want to have the mammography because they are afraid of what they would receive, but with kind of real life, kind of what are the barriers. She did when she was in practice, like for example, there's a ductoscope, a small little, about as wide as a hair, piece of hair, that you would put down the duct of a woman's breast to look for. Patrick, help me here, but I think it was.
Yeah, it's right through the nipple where you go, and you go through, so you can actually do a little mine extraction, and you can actually extract out the fluid to look at some of the cells.
Cytology. And so we're looking for papillomas. And
Exactly.
so again, that innovation, which was patient focused.
Yep.
And so she did that consistently in her clinical care. She worked in a private hospital. They had a lot more resources than I had in my hospital. And so she was able to do that. It also taught me it takes resources to bring that innovation to the patient. If you don't have the resources, the innovation may never get there. And so, that was just kind of what we learned together.
You know,
So,
what a fascinating story. Let me just give you some. I trained at Harvard UCLA,
oh,
so we may
what
have
year did you
crossed
finish?
over. Yeah, so
What year did you finish?
I was a surgical resident and I was a chief resident. I finished in 1979 and I became assistant professor.
Oh, you were
Uh,
just before her because she
yes.
finished in 83. No, she started in 83. Okay.
Okay,
Yeah.
then in 83 I became assistant professor at UCLA. And believe it or not, part of my practice as a general surgeon then was also do the lumpectomies.
Ah,
And but it also speaks to, in a funny way, full circle to today. As you may remember, big academic centers like Sloan Kettering during that time was postulating high-dose Taxol therapy for patients with breast cancer, really high-dose chemotherapy and radical mastectomies, and that was the rage. And what you just talk about, women's, and it bothered me then, and it still bothered me now that um, I have this because I wanted to talk about this, knowing that your wife was a breast cancer doctor. That Taxol, developed by Big Pharma, and the packaging still says this, 2 to 4% receiving Taxol have anaphylactic reactions. Fatal reactions have occurred in patients despite pre-medication.
hmm.
And the reason for that, and most doctors even to this day don't understand, is that Taxol is dissolved in castor oil. Women were getting injected castor oil into the veins. And to me, that was, why are we doing this?
Hmm.
Is there a better way? So you begin to see this evolution of, we have things in drugs that we give first for high dose, it was and it's no longer the case. Radical mastectomies, which is no longer the case. Lumpectomies, which you can do with radiation. So it's fascinating that innovation, evolution, and enhanced enlightenment of thinking, of understanding the biology of what we are doing as physicians. But sadly, we as physicians, and I come from that world that you all come from, academic and in private practice, we are given what we are given, whether it be through the FDA or through Big Pharma. And I think this is the opportunity right now for us to not only change that, because we now have a better understanding ever than before on the molecular basis of both the toxicities and what works. And so that to me was why I think this evolution of cancer now, when you talk about rural health, I'd like to get your thought about that, because one of the most important things is, as Mark brought up, the obesity rates, and especially in rural health and cancer, and what can be done across America to address it. I'd like to get your thoughts on that, Senator.
Yeah, so obesity is clearly correlated with increased risk of cancer for a variety of mechanisms. I'm a hepatologist. I'm a gastroenterologist, but liver disease, for the doctors know this, but the non-docs, is a subset of gastroenterology. I always say liver specialist because if you say hepatologist, people think you do snakes or venereal disease. But in terms of liver disease, when you are obese, you get something called fatty liver. That can lead to scarring of the liver, and that can lead to cirrhosis, which in turn creates liver cancer. So it's among the many diseases: breast cancer, colon cancer. Patrick, you could tell me some more. Obesity is of a greater incidence in rural areas, a greater incidence in lower socioeconomic populations. And there are healthcare disparities between the rural and the suburban urban population. We've got ways to address that. Frankly, one of the ways we're going to address obesity is through the GLPs. It is amazing how the impact that's going to have. And they're going to continue to get better. They'll be in an oral form soon, as an example.
Senator, explain that if you would.
Yeah, so everybody's familiar with Ozempic. I just saw a cartoon today of Jabba the Hutt, who's been on Ozempic, and Jabba the Hutt, if you remember him from Star Wars, who kind of floated around looking like this, and now he looks like a 150-pound, a muscular guy with a six-pack on his belly, and he's denying that he took Ozempic. But of course, everybody suspects that he has. And so, point being that it'll overcome a stigma at some point, and people will be on Ozempic or a similar drug, and that will help with the obesity epidemic. And that's going to decrease our incidence of the obesity-related diseases. I'm optimistic it will decrease the incidence of cancer. And so that said, the rural population needs more access. I think telehealth has the ability to do that. There needs to be a AI-enabled way to help a rural provider practice to the top of her license, and I think that's possible through AI. And then lastly, I think this pharmacological innovations will end up doing a lot of positive things too.
All right, Doctor, with your permission, I want to bring in a community question, if that's okay.
Oh, please.
That's true.
Okay, Holly, welcome in. Tell folks where you are and what's on your mind for our two doctors and our senator.
Hey, I'm in High Point, North Carolina, and I was recently diagnosed with breast cancer as well as a BRCA2 gene mutation, which I'm told can increase my risk for not only breast cancer, but ovarian cancer, pancreatic cancer, and melanoma. So I'm wondering if Anktiva could be beneficial for me, and if so, if you have any advice on how I could pursue that.
Yeah, I think the best way to do that, frankly, is have your doctor. We've been given expanded access now, and my opportunity for your doctor to call and have it available for you directly wherever you are, it probably is the best way to do that. And immunotherapy is an opportunity for you with your breast cancer today.
Holly, we're all pulling for you. If you could go ahead and just go into the chat and direct message me your email address, and we'll figure out a way to be in touch with your doctor. Okay.
Okay, great. Thank you.
Thank you. Dr. Cassidy, I'd love to hear your view on how to best practice for folks who are diagnosed with something like breast cancer. What are your advice to folks in terms of mind and body to deal with a situation like that?
Well, first, of course, speak to your physician, because your physician is going to know your case. And so let me first start off by saying that. Secondly, there is compassionate use programs that the federal government has and that Congress has specifically authorized. And through the generosity of companies, you can have this both expanded access and compassionate use. And so emphasize that. And lastly, take care of your spirit, take care of your body otherwise. It's kind of old, but Patrick will remember the guy at UCLA. Mark, you'll remember the kind of journalist sort of a fellow that got cancer and decided to start watching Three Stooge movies because he realized that if his spirits were picked up, he would do better. And indeed it was. There is something activating about of good things when you are enjoying life. So as much as possible, focus on the positive.
Holly, we're all pulling for you, and please stay in touch with us and get me that information. We'll connect you. Alyssa, welcome in. Question. Tell folks where you are.
Thank you so much. I have a question. This is regarding my brother-in-law. He is diagnosed with appendix cancer, and it's metastasized. And he's been on Folfox for 4 treatments. It didn't help at all. Now he's on Folfiri, and he's losing a lot of weight. He can't consume anything. He can't eat anything, and he's throwing up. And he lost probably close to 100 pounds. Can we go through you to get some, I don't know, how can we get to you to get the BioShield treatment? Does he qualify, or what can we do?
Again, I'm sorry to hear that. You know, I treated 20 years ago, and Senator Cassie understands appendiceal cancer is actually caught early, sufficiently early, is very treatable. I'm sorry to hear that he is now at that stage. Again, I would really emphasize, where do you live, ma'am? Where does your
We're in Los Angeles area.
Oh, okay. Well, that's easy then. Then you know where our clinic is, and so it's CSS
Correct. I've tried to contact it. We can't get any connection.
I'm so sorry again. You know, we've had 10,000. I don't want to make an excuse. We have 10,000 applications so far, and we're trying literally with everyone. If you can just leave your email address, and I think through Mark.
Direct message me your information, okay?
Yeah.
Okay. Thank you. Senator, may I just sort of, and I don't want to talk about our drug, I really don't. I want to just talk about the disease itself. It's really painful. You know, I've done the show now with Mark. I think this is our 5th episode, and we keep on getting this painful, distressful calls, because I honestly believe, sadly, we as doctors, and as well as whoever's developed the drugs in evolution, and we went from, you know, blood leaching, as you leeches, now to this chemotherapy and radiation, which is completely upside down in my mind, because the only thing that matters in the patients, as you said, when you say keep your spirits up, is activates the natural kill. It activates your immune system. And this patient, and Mark was talking about, you know, weight loss, and this patient with Folfox and Folfirine is predicted. They'll have ulcers in their mouth. They'll lose weight. It's the most toxic materials you can put into your body without killing the patient in their last throes of life. But more importantly, I can predict that that patient will have no natural killer cell or T cells. So I was hoping to bring on Dr. Simon Hugg, who was part of our first episodes, in which, as you know, glioblastoma, recurrent glioblastoma, has an overall survival of less than 6 months. And the standard of care treatment is radiation and Timidor, which again knocks out 100% of your NK cells and T cells. It's like saying we have Epogen today because you want to maintain your hemoglobin. The reason you want to maintain your hemoglobin is because we need oxygen. And Epogen, and we have Neupogen today because we want to maintain your neutrophils. The reason we want to maintain your neutrophils is because you want to prevent infection. And yet, oxygen, vital for you to live, and neutrophils, vital for you to prevent infection, have no effect on treating cancer. Yet, the reason you give Epogen and Neupogen is because you can give more chemotherapy, which wipes out the natural killer cells and T cells. So my concern is that this, I don't know the word madness, but this realization of this vicious circle, so vicious cycle. And just like as we talked about at the beginning of this talk, total radical mastectomy, which was horrific, where they even removed some of the scapula and the bone and disfiguring, tied to high-dose chemotherapy, not, I think, 20, 25 years ago was the standard of care for breast cancer. So I think we need to talk about really how we think through the immunology today. And Mark and I were talking about what is China doing? And we watched China, and I watched China, and they have moved on now really into this field of immunology, and they are moving very, very fast. So I hear all these. It's very painful to do these sessions, and it's very painful for us to say, I'm going to try to get to you. It's 10,000. We now up to 11,000 requests, but time is of the essence, and cancer is a war against time. So, Mark, I think you have another.
Yeah.
I'm
next. Okay,
question.
Mike, welcome, and tell folks where you are and what's on your mind for the doctors.
Thank you very much. I first just I'm Mike Warner. I'm from Chicago, the Chicago area. I want to thank all three of you for this whole show and the whole cancer decoding. I think it's phenomenal.
Thank you.
Doctor, I've been diagnosed with prostate cancer 3 years ago. And I chose not to do radiation at the last minute. I walked out. I didn't do it. And I went to Dr. Shalov in the University of Chicago Medicine and did a HIFU treatment instead and had a partial, about 60%. And now my numbers are back up again, and my PSA numbers are starting to climb. Is BioShield something that could help I'm otherwise extremely healthy. Would BioShield be something that would help my immune system, and is prostate cancer capable of being healed that way?
Yes, we have had, Mark, I can't remember whether we had the patient Alan Portell on the show yet or not, but the answer is we've already done these trials now, and where it again was one of these compassionate special purpose INDs, very much like your situation. And the PSA is now completely normal after actually resurrecting the lymphocyte count. There's a trial now going on in which the idea, when you give radiation and you give radiation plus androgen dependent or ADT, where you remove the androgen levels, where we can avoid the removal of the androgen level. That trial is going on. I think there's a trial which hopefully Dr. Hug will come on and talk a little bit about, where we can avoid radiation for glioblastoma, which will be a revolution, because that's been the standard of care for 45 years. And sadly, people getting radiation for glioblastoma are no longer themselves, because the way they do this, you do the treatment, you do the surgery, remove the tumor, because you can't see the rest of the tumor, you have to radiate normal brain around the tumor. And these patients then after that are ghosts of themselves. And it's just, we do that because that's how it's been done for 30 years. So I think, as you said, we are now in an era of enlightenment. So I would encourage you to go to your doctor in Chicago, have him call us. We will make the product available as part of the expanded access, because sadly we cannot. I know you may be calling into the clinic. It's just impossible for us. I want this across the country.
Yeah, Mike, thank you. Send us your information or be in touch. Senator Cassidy, the previous president, and again, it's not a political question, talked about a cancer moonshot, really dedicated, rhetorically at least, the concept the United States was going to beat this and be innovative and put the best science forward. Where did that leave things when President Trump took over? And are we still in the midst as a country of a cancer moonshot?
Well, first, and Patrick can say this, we've made incredible progress in cancer. I have a friend who's now had melanoma for 10 years. I mean, when I was in medical school, you got melanoma, they said, go make your will. And now people are living with melanoma. And it's interesting because Patrick pointed out the older therapies would be radiation, and now the new and the bone would collapse because the radiation would kill the osteoblasts, the ones that cause the bone to grow. And now with the immunotherapy, the tumor kind of shrinks away and the bone grows back and the spine does not collapse. I was just speaking to someone today, and again, Patrick's going to know it better off the top of his head, but a certain type of colon cancer, 5 to 6%. There's a drug in which they don't have to resect it anymore. The tumor just melts away. And so I say all that because we've made incredible progress on cancer. Patrick's point as well. Breast cancer, prostate cancer, people typically don't die from those now because we have such effective therapies. They still can, but they typically don't. But there's a whole lot more to do. And as fewer people die from heart disease and they live longer, they're going to get something else. And in some cases, that something else is cancer. Where does that leave us? I think that there's been some, I think I got on just as Patrick was talking about some of the changes. I think the changes at the NIH, we have to wait and see how they're going to transpire. There's an effort to put more of the funds towards research and less of it towards so-called indirect cost. If that's so, there'll be more money for research. That's a good thing. There's been some disruption, and it's kind of wait to be seen. Is that disruption going to make it a better, more efficient research funder, or will there be some sort of infrastructure that needs to be rebuilt? I don't know the answer to that. We can all hope that it's all for the better because we want these cures being discovered.
Lastly, Senator, before you have to go, for people in America who don't know senators, aren't connected to the government, if they want this country to do more to fight cancer, what can people do? What's the way, if that's the will of the people, what's the way to express that to elected officials?
Well, first, if you know somebody who's got a cancer which is failed local therapy, because the large, like 80% of cancer therapy is in community hospitals. But the NIH has a website. They've got clinical trials going all the time. And it may be if someone qualifies for that, all their medical expenses are paid for. And so I just say that is a referral hospital, even if you do not have other resources. Secondly, refer them to this podcast. You're talking to one of the world's experts on innovation when it comes to cancer. That's a good thing. Thirdly, going back to what you just said, we live in a representative democracy. And people think that just because they're a single citizen, that they cannot impact public policy. I promise you, everybody on this call knows somebody who knows somebody, your congresswoman, your congressman, or your senator. I went to high school however many years ago. A girl calls me up from high school. She says, "Can I talk to you? My son has mental illness and he can't get on Social Security disability because he was diagnosed after age 21. Everybody on this call knows somebody with serious mental illness. Of course, I'm going to listen to them. And now we're working on legislation that will address that problem for everybody like her son across our country. I can't tell you it's going to happen tomorrow, but because she took the effort to reach out to me, it's going to happen sooner or later. Similarly, wherever you live, if you live in North Carolina, make an appointment with your congresswoman, congressman, or senator. You may speak to a staffer, become an advocate, follow up, give them a little bit of information, ask if you can follow up in 2 to 3 weeks to follow up, and continue to follow up. You keep knocking on that door, and someone's going to answer. There is a wonderful kind of parable in Scripture where Jesus speaks about the persistent widow, and she keeps on bugging the judge. And finally, the judge says, "I fear neither God nor man, but I'm tired of that woman." And that's what we are encouraged to do. And I would encourage you to do that with your elected official as well.
Senator, we're so grateful to you for making time. And again, you're just a model for people in public life who are in it for the right reasons and bring your expertise from the private sector. We've got plenty of lawyers in Congress, as Dr. Patrick said. It's nice to have a few doctors.
I couldn't agree with you more, Mark, because I think the senator As when I first met the senator, I was so enthralled by not only his passion as a physician still, and his passion to help this community and the people. And I think Louisiana's should really be proud to have this kind of quality of a senator representing them. And I really want to thank you, Senator, for your time. If you've got time to listen to some more of these people, I'd love to hear do that, but I understand you really in a busy moment. But I really want to thank you for your time, because your contribution, both as a physician and as a senator, and giving advice to the people, is not only heartfelt but really important. Thank you.
I thank you all for having me. And I lastly thank you for the people that told their personal stories. You are making the case for why there needs to be faster approval of drugs and more options. And so thank you for sharing your story. And as an elected representative, that means a lot to me.
Thank you, Senator. Grateful to you. Thank you for being on. All right, we're going to bring in another doctor, returning guest, Dr. Kagi, Simon Kagi, who joined us early on and back for an update. So I turn it over to Patrick, and then we'll get back to community questions after we get an update from Simon.
Well,
so,
Dr.
Patrick.
Huggy, thank you, Dr. Huggy, for your time again. I know I pulled him out of clinic because I said it was so important for us to hear, because he's been sharing with me the progress. And I think you heard even more so the pain of the patients now getting radiation and getting the chemo. And what I'm excited about is Dr. Huggy is now contemplating starting a trial, and we're going to help him do that, in which patients with glioblastoma, and we can solve this for glioblastoma, you can solve it for any tumor, will actually be able maybe get through the whole thing without radiation, and using a very novel, again, innovation called tumor treating field. So before we start, Mark, we pull up that's the results of the first patient, which I showed way back, and then results of the second patient. So this is the second patient, and Dr. Huggy, do you want to just speak to this patient again, who received no chemotherapy and had failed radiation, and now is in this what you call recurrence, in which sadly the survival rate is less than 6 to 9 months, and received this innovation treatment of yours. If you may want to just talk to that, I'll leave the platform open to you now about that.
Yeah, well, thanks for having me again, guys. I love talking about these cases. I think they're very inspiring. So this is a patient of mine who has a glioblastoma. They tried to remove it. They could not remove the whole thing, which is very common with glioblastoma. He did receive radiation and chemotherapy combined, went on another sort of immunotherapy trial with chemotherapy and did not do well. And he came to us and started the trial where we're using the novel technology developed by Patrick, as well as a device that's currently FDA approved for glioblastoma called Optune, and it is worn on the scalp. And what it does is that it emits basically an electric field, which is not like electrocuting anybody. It's a field, almost like a radio wave that bounces back and forth, and that bouncing back and forth confuses cancer cells and causes them to die. But the way they die, the process of them dying actually stimulates the immune system locally in that tumor, where the tumor becomes now the target for basically what Patrick is trying to do, which is stimulate the immune system, get the NK cells into that area and start killing the cancer. So it's basically creating a beacon, a very, very powerful beacon that these cells and the IL-15 drug that Patrick also developed basically stimulate these cells to go there and kill the cancer. This MRI is basically a proof of concept, but it is utterly remarkable to see a glioblastoma that has come back actually start shrinking down to and shriveling down to a much, much smaller size. This is a 50% reduction or more in the volume of disease in that area. Truly remarkable. And the patient's doing great. Very, very, very minimal side effects, if anything. and living his best life out water skiing with his family now.
Could we show the other, there we go. That's a first patient we showed weeks ago, and wonderful to see this progress. Simon, if you could continue describing this patient.
Yeah, another patient, recurrent glioblastoma, as Patrick mentioned, 6 to 9 months maximum survival when this disease starts to grow again. It's extremely aggressive, very hard to treat. This is the case with the baseline scan back in March. 2 months later, after 2 cycles of treatment, you saw it shrivel down. There's much less white stuff in that area, so where it's circled, much less white stuff, suggesting less tumor. And then 2 months later, after that, you see even less disease at the site. So again, this is even stronger evidence for using the device, like I said, Optune or Tumor Treating Fields, that are FDA approved for glioblastoma, and actually now FDA approved for lung cancer. And so that's very exciting that patients with lung cancer have now the option to use Optune as well for their disease.
Thank you. So inspiring, and it's incredible to see it so graphically and so clear, the kind of progress that can be made. Let's bring in another community question from Tammy. Tammy, welcome in. Unmute. Tell folks who don't know where you are and what's on your mind for the doctors.
Hey, I've been on before the official Cancer Decoded happened, because I spoke about my dad who had bladder cancer and passed. But Doctor, I was watching you on Megyn Kelly probably this last week with regard to autoimmune and COVID. And I was wondering, you were speaking to the fact that people can do something with regard to maybe take a BioShield, something along that line to kind of reverse autoimmune disease. With regard to the medicine. And what I'm trying to figure out is, did I misunderstand what you were saying in that space? After I had COVID in 2021, and then I had to get a vaccine to go back to work. And then I have autoimmune now, and I have rheumatoid arthritis. It's not that bad, but a coworker and a friend, they actually have PMR, which is really bad. And he's going to like Mayo Clinic and whatnot. And you had just kind of reference with regard to working on the immune system and trying to reverse the impact of what's happening with regard to COVID. And I'm not sure if I heard what you were saying in that space correctly.
So it's a complex, long answer, but let me try and tighten it and shorten it as much as I can. At the end of the day, I believe what's going on, and we have ongoing science to prove it, but there's very powerful, suggestive scientific evidence that the spike protein, whether it's from the vaccine or whether it's from the virus itself, is the cause of creating antibodies against it because it persists and it's in different cells of the body. And when it's there, it's an abnormal protein, and your body reacts to it by creating antibodies, and then you get what we call autoimmune disease. Mm-hmm. So therefore, the theory would be, and this is where we're doing trials now, is if we can rid your body of those cells that are infected with the spike protein, because your cells, if that's the cause, if we can rid the body of those cells infected with the spike protein, would we reduce the effects then of what we call long COVID? Now, long COVID is a multifactorial, multi-organ disease. People have different, whether it be brain fog, whether it be kidney disease even, whether it be cancer, whether it be rheumatoid arthritis, whether it be autoimmune disease, different autoimmune disease. So that trial is about to begin, both at UC San Francisco and in Los Angeles, where patients with long COVID can come in and get the BioShield and explore whether the inflammatory markers, which we can measure in the body, decreases, and whether the symptoms decrease. Does that explain?
Yeah, and I guess my question is, do you go to your website to look at that, or do you go to clinicaltrials.gov that you spoke about earlier to look at that?
Yeah, so I think that it'll be open in clinicaltrials.gov in a couple of weeks. It's going through what we call the IRB approval status right now.
Okay, I'll pass that along to my friend.
Tammy, thank you. Grateful to you. Neil, welcome in. If you could unmute, tell folks where you are and what's on your mind for the doctors.
Yes, Neil Rebar in Minneapolis, Minnesota. And Dr. Soon-Shiong, I have a question. I've got prostate cancer. It's P10 null with Tempris 2-ERG fusion and PIK3CA activation. I've had a total of 45 rounds of radiation, 2 years on androgen deprivation and periodic androgen deprivation. And the cancer has come back. It's gone to strange places in me. It's in my pleural area, wrapping around my lungs now. And it's up right near my heart now and in my spine. And I also have lymphopenia, 600 count on lymphopenia of my absolute lymphocytes. And my doctor at University of Minnesota, Masonic Cancer Clinic, said that he communicated with a Dr. Gully, James Gully at NIH, and he didn't think it would be a good idea for me to have it to have BioShield with prostate cancer. And he won't even listen to me about the lymphopenia treatment, although I think it's warranted. Do you have any advice?
Well, that's surprising because Dr. Gully is actually doing trials with our, with our what you call BioShield, and Dr. Gully and Dr. Jeffrey Sloan. So I'm a little confused about that. He's a good man, so I'll try and find out. The fact that you had Tempris, and getting a little technical, but the fact that you had Tempris in your prostate, did you have COVID or COVID shot?
I had one Johnson & Johnson, but I've had the prostate cancer since 2019. I had the surgery for a radical removal, and I actually had the symptoms since 2014, but I was refused a PSA test for all those years from 2012 because of my clinic. Another part of the University of Minnesota followed some kind of government guideline when they stopped doing PSA tests. They thought they did more harm than good.
Wow. Again, I'm surprised. To be honest, I'm really surprised about that, especially if you had prostate cancer. That's one of the ways to check what you call biochemical recurrence, since it's the only way to do that is through your PSA. Look, nonetheless, the reason I bring up the Tempris is because the Tempris, together with COVID, the spike protein, Tempris activates the ability of the spike protein to get into different parts of your body. Having said that, what you have now what we call very advanced biochemical recurrence, but there's a treatment for it. That's the good news. There's a real treatment for it. So again, I would urge you, sorry to do this to you, but contact our clinic. And there's another, Dr. Finkelstein and Dr. Bazanka, who have clinics on the East Coast, who are about to use the BioShield for prostate cancer. That trial is about to begin, probably again in a month. And I just literally got off the phone with them this morning, and I'll try and get you their contacts on the East Coast.
Patrick, where are they on the East Coast, and with whom are they affiliated?
I don't know the name of the clinic, or it's Urology Associates, right? And it's a very, very, very big group. And Dr. Bazanka was actually speaking, and Dr. Finkelstein came from the NCI, as it turns out. I'll try and get you that. I apologize. I'll try and get you those contacts. And that trial will begin, and you should reach out to them to see. If not, our clinic could help you with a compassionate use.
Neil, direct message me right now your email address, okay?
Sure. Thank you very much.
Okay, thank you. We're right at time, so as always, grateful to everybody for making time, and we'll have more opportunities next week.
Can I just ask for whoever's interested to reach out to Dr. Huggy at Hoag Medical Center, and I think what he's doing is revolutionary. I think that'll completely change the course of glioblastoma. And we shared, just Dr. Hage's results with some of the nation's top experts at Cleveland Clinic and at Duke and at UCLA and even at St. John's. And all of them came back incredibly impressed that he's onto something very, very important. So he's at Hoag Medical Center, whoever wants to reach out to Dr. Hage with glioblastoma, whether newly diagnosed or whether recurred. And again, his trials are ongoing.
Hogue, right? Hogue.
Hoag, Hoag.
Oh, sorry. Spell it again.
Hoag. Hoag.
Okay. Hogue.
It's in Newport Beach, Los Angeles.
Okay.
Newport Beach, yep, California. Nice place to visit.
Okay. Grateful to all three doctors and grateful to you for being part of this community. And although, we all feel so sad when we hear your stories and what people are dealing with, I think Senator Cassidy gave us some pretty good optimism to remind us that a lot of cancers now are not as life-threatening as they were. And the work of Dr. Hage, the work of Dr. Soon-Shiong, there are some of the smartest and most dedicated people in the world working to try to deal with it. But until it's really solved, we want to build this community. So please share the program with others who you think might benefit from being part of it. So thank you. Again, thank you to both doctors and to Senator Cassidy. And we'll see you next Tuesday night, 7:30 Eastern time for Cancer Decoded. Thank you for watching. Have a great evening.